Good afternoon. My name is Ben Satterfield. It's a pleasure to speak with you all again this year. Obviously, I wish it were in person and I could see your faces, but we'll make do as best we can. The topic I'll be speaking about today is palliative care and hospice. So I wish to discuss, first of all, the spectrum of medical care, and then define palliative care and define hospice, and explain how they fit into this spectrum of medical care. I also wish to clear up some misconceptions regarding palliative care and hospice. And then we'll spend some time discussing death in the United States, including wishes and reality, trends and expenses. Now, I don't want this to be a morbid conversation whatsoever. In fact, I do think you'll all probably find it quite interesting and hopefully helpful. So let's begin. The spectrum of medical care. So, for most folks and most physicians, when we think about medical care, we're thinking about curative care. What can we do to cure specific diseases? Now, unfortunately, there's many diseases we can't cure, so I'm adding in here as well chronic management. So, things like high blood pressure, diabetes, heart failure, many conditions that we don't have a way to cure, but we do have pretty good ways to manage them with medications and other means, at least for a long time. So again, for most people, as they're interacting with the medical system, this is what they're thinking about, and rightly so. However, there is a flip side to this, and that's what we'll be spending a fair amount of time today talking about, and that is palliative care. Now, we'll go into the details of this in a minute, but palliative care is something that can be incorporated early on in any disease course and continue on. What this is trying to show is as time goes on and as a disease progresses, there may be fewer and fewer treatment options, they may become less effective, and utilizing something like palliative care, which focuses very much on symptom management, becomes more and more important as time goes on. And palliative care continues on even into the next phase where basically we stop focusing whatsoever on curative care. And this is something called hospice. Again, we'll spend a fair amount of time talking about this here during our conversation. But towards the end of life, hospice care is a different paradigm and way of thinking about treatment, and palliative care can continue on through that time, leading up until death, and then bereavement care for family members and other loved ones who survive a patient who's passed away. So, what is palliative care? Well, this is an interdisciplinary care that aims to relieve suffering and improve quality of life for patients with advanced illness and their families. And again, this is how it's usually used. It certainly could be incorporated even early on before illnesses get too advanced, but for the most part, this is for folks with advanced illness, and it is a way of thinking and treatment that really focuses specifically more on relieving suffering and improving quality of life. Now, as is mentioned here, it is offered simultaneously with all other appropriate medical treatment. So this isn't you do regular medical treatment or you do palliative care. This is something that goes along with your regular treatment, but is also, again, specifically focusing more on relieving suffering and improving quality of life, and focusing on those aspects, which sometimes those of us who are physicians treating very specific illnesses may not be focusing maybe as much on those as perhaps we should, as we are trying to really treat, to cure, or manage certain illnesses. So palliative care addresses both the symptoms and the stress of living with a chronic illness. Again, that's something that often many physicians that we have to work on trying to remember that not only are we trying to really treat symptoms, but folks who have these chronic illnesses, it can be a huge stressor in their life. And the palliative care teams are very good at looking at that whole picture and treating the stress through various mechanisms and helping to just address those items as well as the symptoms of the disease themselves. Palliative care also involves support for loved ones and caregivers. Certainly, as you're probably aware, having these chronic illnesses often gets to the point where individuals can't take care of themselves in all the ways that they would like, and they really require the help of a caregiver. Usually that's family and other loved ones, but that can obviously be a big burden on them, and palliative care does a wonderful job of reaching out and working with these caregivers as well to make sure that they have the support they need to make things make it as low of a burden on them as possible. Most importantly, palliative care is based on an individual's needs. And therefore, it varies very much from person to person. A care plan may involve really any of these following items. Doesn't have to be all of them, but it can be any of them. So again, alleviating symptoms, including the side effects of treatment, and making sure that a person's quality of life is not being hampered too much by side effects of the treatments that they might be receiving. It also focuses on improving understanding of illness and its progression. Again, this is something very important that for both the patient and their family members and caregivers, spending the time that the palliative care team will usually do on making sure that the patient and their family understand what the illness is, what its course is, how it's likely to progress. It can be a huge benefit to these patients and their caregivers, really just understand that better and know what their expectations should be. And that in and of itself can help relieve a lot of the stress and anxiety about not knowing what's coming. It can involve identifying and addressing practical and spiritual needs as well. Helping to cope with feelings and changes related to the illness. Again, all these points looking at the whole person and trying to help treat all aspects that they need to have a good quality of life. And that may not necessarily just include treating only the illness. Assisting in understanding treatment options, making treatment decisions, and coordinating care. Their palliative teams are amazing at sort of being the quarterback and helping, again, to coordinate care, helping navigate decisions if there's multiple potential treatment options and deciding, well, what's best and what's not. Again, this certainly involves the physicians offering those treatments, but the palliative care teams have just a unique way of looking at this and working with patients to help come to these really understanding and making these decisions. Lastly, it can involve identifying and accessing additional resources to provide support. So whether that's community resources or resources from whether it's the general community, religious communities, etc., to really help out the individual and their caregivers. So palliative care can be an option in many conditions. I'd say that probably the three most common ones that we find it especially helpful in are patients with cancer, with dementia, and with chronic obstructive pulmonary disease or lung disease, COPD. So I'll go through some specifics on those three diseases, but it certainly isn't limited to just those. I mean, I've seen this utilized very well in folks with really any advanced chronic illness. So advanced heart failure, pulmonary hypertension, interstitial lung disease, diabetes with complications, if they're losing eyesight through multiple amputations, kidney disease, all those things, as well as many other disease types that really palliative care can be a big benefit in. But let's talk a little bit specifically about probably these three most common ones that I mentioned. So palliative cancer care varies depending on the type of cancer, obviously, and the symptoms it's causing, the treatment options that are available for it, as well as the age and prognosis of the patient. But this usually will include things such as managing side effects of the chemotherapy or radiation or even surgery. Treatment of anxiety and depression, which are very common and understandably so in individuals who have a cancer diagnosis. And again, not just only treating the cancer, but treating that whole patient. And if they have anxiety and depression from this, working with them to manage that, as well as helping family members to plan for the future. So in the case of dementia, palliative care teams often will, again, help treat the anxiety caused by the dementia. As I'm sure you can imagine, as dementia progresses in an individual, it's a frightening and anxiety-producing thing. And making sure that that side of things are managed appropriately. And as the illness progresses, it may involve helping family members make difficult decisions about things like feeding or caring for their loved ones, right? If the dementia is progressing to the point where a person stops eating, do you move forward with force feeding? Do you put a peg tube in the stomach to do feedings directly into the stomach to make sure they're getting nutrients to continue to live if they're not eating orally? You know, there's not a right or wrong answer there, but it's difficult decisions that the family members need to make. And the palliative care teams are very good at helping walk them through those options and deciding what's best for their loved one, their patient. And again, critically important to offer the support to these family caregivers, as this is a very taxing position to be in. And then lastly, the last specific disease I'll go through here for palliative care is COPD. Again, something we see very commonly used, but they might do things such as using medications to treat air hunger sensation, right? As this is a lung disease, and in advanced COPD, despite the medications and inhalers and treatments, you can get to the point where there's very significant air hunger. And there are options we can have to help relieve those symptoms so that they feel much better. Treatment, again, of anxiety and insomnia that are often associated with this difficulty breathing. And assistance with smoking cessation, which can at least slow the progression of the illness. So those are just some examples of how they might be involved in some different diseases. A palliative care consultation often occurs in the hospital, and this would be because, there's dramatic changes in the condition of a patient or new diagnoses, and as they're trying to understand that and work through it and decide what's best, palliative care is often very helpful. So in the hospital, in those sort of acute changes. But that's not the only place for them. Certainly, this can occur as an outpatient in more slowly progressive diseases where there hasn't been a sudden decline, but more of a slow progression of the disease. It would be absolutely appropriate to involve the palliative care teams and begin those conversations. Any primary care physician can arrange a consult. They're very familiar with this, and they aren't going to take offense that if a person wants to meet with palliative care and discuss things as well. They would be encouraging that and supporting that, I'm sure. So let's clear up a few misconceptions about palliative care. Palliative care does not mean that doctors have given up on the patient. All right, if they suggest this, they aren't saying, oh, well, I'm done, we're going to hand you off to the palliative care team. That's not what it means. It's something they'd be working together. Again, palliative care is something that is offered in addition to all regular medical treatments. Palliative care does not mean end-of-life care. or although they are certainly very good at having discussions about thinking about what might be involved in the future with end-of-life care and goals of care discussions and getting a patient to prepare for that down the road. A palliative care consult does not mean that a physician thinks that the patient is near the end of their life. They're not the same thing. And palliative care does not mean, again, that you have to stop treatment or attempting to cure whatever diseases the patient has. All right, this goes along with treating the diseases, not it's not an either or type of situation. Again, we come back to our spectrum of medical care, our curative care and chronic management, whereas palliative care spans all of that from as early on as a patient would like, and probably the earlier the better, really, all the way through to end of life care. It covers really the whole spectrum and is assisting in managing symptom control. Okay. Now let's spend a little bit of time talking about hospice, which is a different entity from palliative care. Many folks tend to lump them together, and although palliative care can help transition things into hospice when that's needed, they are two very separate entities. So let's talk about hospice. Hospice is a concept of care designed to provide comfort and support to patients and families when cure-oriented treatments are no longer desirable. So some people may say, well, when would that ever happen that a cure-oriented treatment wouldn't be desirable? And for some people, that may never happen. For others, it may be if the side effects of the treatment, whether that's medications, again, or radiation or surgery, if the side effects of that would make quality of life untenable, then that's when we say, okay, well, curative treatment isn't the best option for that person. And really, that's an individual decision that a person has to make themselves. But if the side effects are going to be worse than the potential cure, then they're at a point where that's no longer the goal. The goal isn't to try to cure this because it just isn't worth it or isn't possible. And therefore, to really focus on comfort and quality of life. So hospice care really prioritizes those two things, comfort and quality of life, mainly by reducing pain and suffering and anxiety, and focusing on those so that whatever time a person has left, they aren't dealing with it in excruciating pain and being very miserable, but rather having the best quality of life that they possibly can have during the time that they have left. Very importantly here, hospice neither prolongs life nor hastens death. It's not trying to treat the illness, trying to make it so that a person lives longer, but it also certainly is not hastening death. Again, it is making sure that whatever time a person has left as the disease takes its natural course, that they are not dealing with pain and other symptoms, but rather that that's being managed and that that's the goal, is to give it good quality of life. And interesting and a big important aspect to me that I find with this is that hospice can often give an individual the opportunity to select the location of death or have more control over their surroundings when it's going to come time for them to pass on. That they can plan for that ahead of time and have those, and have a say in what that's looking like, really. So in order to enroll in hospice, what is needed? There's really only one criteria. Two physicians need to certify that a patient likely has 6 or less months to live if the disease follows its usual course. Those physicians usually are the primary care physician, or maybe in the case of, depending on what the disease is, it might be an oncologist for cancer or a cardiologist in advanced heart failure or something like that. But you have typically whoever the primary physician is for that disease, will usually certify that, as well as then the hospice medical director. So those are the two physicians. That's the only criteria needed in order to enroll in hospice. Now, what if a patient lives longer than 6 months, though? And that's where my picture down here is. None of us as physicians have a crystal ball. None of us know when any person is going to pass away, right? We can have a general sense of things based on how the diseases usually roll, but it's always variable in people. So what happens if the physicians say, we think there's less than 6 months to live? You get to that 6 month point and the patient's still alive and doing okay. Well, a patient can simply be re-enrolled as long as the physicians still feel that the patient from that point likely has 6 or less months to live. In fact, I'll say I've run through this situation a couple of times where people have certainly done this. I think the longest I think one person re-enrolled 3 times before finally passing away. And again, that's wonderful, having good quality of life during that time, and that's perfectly fine. It's great. So, where does hospice occur? Well, ideally, it'll usually happen wherever a patient calls home. So it might be a private home, it might be a nursing home, or other sort of long-term type facility. Wherever it is a person is usually living, that's where ideally hospice is occurring. Now, if a patient has a dramatic decline in the hospital and is unable to be safely transported back home, it can be arranged as an inpatient. This is a situation that happened with one of my grandmothers. She had a stroke, ended up in the hospital, looking at sort of her overall medical condition and the very poor quality of life she would have if we did manage to get her through this. As a family, all decided that hospice would be the best course for her, just making sure that she was very comfortable. And the physician team felt that it wouldn't be very safe to transport her back home, probably wouldn't have very long to live if everything else was withdrawn. And so she remained in the hospital for a couple of days till she passed away. This is something that certainly can happen if people need very large amounts of oxygen in order to be comfortable, or things like that, where that just can't really be delivered in another situation, then it can be arranged inside the hospital. But again, ideally for most people, it would be done within their normal home setting. And then for patients who have more complex needs, then the family is really able to provide at their home setting, but they don't need to be in a hospital. Then it's becoming more and more common to utilize things called hospice houses or hospice facilities, where they are specific facilities arranged only for hospice care. Usually they're in very peaceful, tranquil settings. And there's nurses available all the time to help out, again, in more complex situations than a family can really provide. The question comes up particularly with cancer patients, but in some other situations as well. Well, what if you enroll in hospice, but then a new therapy or clinical trial becomes available that might be able to treat the illness? What happens then? Well, it's simple. For any reason, doesn't have to be just because of a new medicine or trial, but for any reason, a patient can unenroll from hospice. And if they want, they can always be re-enrolled later. There's no penalty or anything along those lines. Again, this is all focused on what is really best for the patient. And if at any time they decide hospice is or is not the best thing for them, then they can be enrolled or unenrolled. And I've certainly seen it with cancer patients where they were on hospice, a clinical trial came out that they were eligible for, they unenrolled from hospice, joined the trial, and if it's successful, that's wonderful. If it's not, and they decide they want to re-enroll back into hospice, then absolutely they are welcome. So we've been talking about hospice as this entity, but what exactly does that entail? Well, Nurses are available to assist with medications, and particularly to teach family members how and when to administer them. In most cases, nurses aren't there in the home or on site 24 hours a day. There are some cases where that is, but in most cases that's not needed, and they can simply teach the caregivers exactly what they need to do. There's also physicians that are available to assess the patient whenever is needed and to adjust the medication regimen, again, as needed to control symptoms. Right? If someone has a disease that's causing them very significant pain and that's something that's progressing, the amount of pain medication they're on early on may not be sufficient as time goes on, and the physician will assess that and make adjustments as needed, again, to just make sure the patient's symptoms are completely under control. The most common symptoms that are treated during hospice really are pain, anxiety, and air hunger in the case of lung diseases. Certainly any other symptoms that need management will be taken care of as well, but those are certainly the three most common ones as folks move towards end of life. Medications are typically covered by the hospice program. And, this isn't just about medications. Other things, supplemental oxygen can be used for comfort. Physical therapy, respiratory therapy, and so forth can absolutely be used if that's needed. Again, this is all about helping the patient feel comfortable and having good quality of life. So whatever is needed for that will be arranged. Again, this is a very multidisciplinary team of experts. You have the medical director of the hospice program. You have other physicians who are assessing the patient, nurses, certified nursing assistants, as mentioned, other therapists, physical, respiratory, etc. There's bereavement specialists. Those are particularly helping the family members who will be surviving the patient. There's chaplains available to help with spiritual and religious needs. Many volunteers. As I'm sure you can imagine, it might not be possible for family members to be with a patient 24/7. In hospice, it's very important that patients aren't left alone, that as they're moving towards end of life, that there's people there with them. And as often as possible, it's great to have family members and other loved ones there. But when that isn't possible, other volunteers who can be there to talk with the patient, read to them, do puzzles with them, whatever it is that they would like to do. So there are many very wonderful volunteers who help with this. And then a social worker is always part of the team to help navigate some of the various aspects of this, both on the medical side, but also things like planning for a funeral and what to do with the body when the patient does end up passing on and so forth, so that able to really walk the family and other loved ones through that process to make it as easy for them as possible. So what's the cost of hospice? Well, first of all, the vast majority of patients on hospice are covered on Medicare, 85%. Some on Medicaid, some on private insurance. Very few end up paying for this out of pocket. And even those that do, there's usually some assistance programs available for them. So these are the rates of reimbursement for Medicare in a couple of years ago in 2018. So for routine home hospice, again, which is what the vast majority of folks are on, $193 per day for the first couple months, then $151 per day thereafter. Compared to most medical expenses, that's actually very low. And again, this is usually typically covering the cost of the physician, the nurses, the medications. It's all incorporated in this. There's usually not co-pays on any of this. Again, it can vary a little bit on private insurance, but with Medicare, there aren't. There's this continuous home care. So again, this is in some special circumstances where, because of the complex needs of a patient, they really need someone with medical expertise there all the time, a nurse. So whether this is taking place in a home or in a hospice house type of situation, obviously that's a bit more expensive, and this is what Medicare reimburses for that. And again, usually there's not an expectation of additional pay by the family, although there are variable situations with that. Hospice offers respite care. Now, this is really a wonderful program that's incorporated within hospice, where, as you can imagine, the amount of time and stress on caregivers to be with someone in end of life care is very high. And especially if this is someone who fortunately is doing well in hospice for weeks and months, it can be obviously a stress and a burden to the caregivers. Well, there's inpatient respite care where, for a certain set period of time, days, depending on the exact situation, the patient can be brought into a special hospice room in a hospital, typically, where it's a very comfortable type of room. But they're there being watched more on sort of the routine home cares that would be expected, but this gives the caregivers an opportunity to go on a vacation or to go do whatever other life things they need to do for a period of time, and not have to think about being a caregiver 24/7 for a certain period of time. So it's respite care for them. And then lastly, general inpatient care. So this is where, if again a patient's in the hospital, acutely declines, is quite needs a lot of cares, and it's not safe for them to really be transported back home, then this is again, that can be arranged within the hospital itself. So let's clear up some misconceptions regarding hospice. Hospice does not mean that doctors have given up on the patient, right? This is it may be that there aren't treatment options left, or again, it may be a patient decision that the treatment side effects are not worth it and to move on. But hospice, this is just a different way of caring for the patient, and in many ways can be more humane than continuing some of the treatments, as this is focused purely on making sure that they are not in pain and discomfort. It doesn't necessarily mean that the patient is imminently dying. Certainly there are cases where a patient isn't enrolled in hospice until a few days before they pass away. But ideally, they'd be enrolled in hospice weeks or months in advance. So although they do have a terminal diagnosis, it doesn't mean that they're imminently dying. And very importantly, this is not euthanasia or assisted suicide, right? This is not hastening time to death. This is allowing the disease to take its natural course. This is important for two reasons. One, for anyone who is looking for euthanasia, this is not what this is. And secondly, for describing it to family members, this isn't, oh, the family isn't killing them if they put them on hospice, right? This is allowing the disease to take its natural course and making sure that they have a good quality of life and are not in pain while that happens. So now that we've discussed palliative care and hospice, let's end on talking a little bit about death, and then we'll wrap it all up together. So, what are the top causes of death in the United States? Well, in 1900, it was mostly infectious causes: influenza, pneumonia, tuberculosis, infectious causes of gastritis and enteritis. So those are your top ones. And then there was some heart disease and stroke in folks who happened to live long enough to develop those. Well, 117 years later, the scene is a little different. Number one is heart disease, followed closely by cancer, number two. Those two make up almost half of all deaths within the United States. And then in 2017, it was accidents, COPD, and stroke as the next three. Those sometimes will switch places with each other a little bit, but they're all pretty close there. Now, again, 2020 is an odd year. My understanding is that actually COVID-19 is actually the number 3 cause of death in the United States right now. But in most typical years, these are your 5. And because of that, particularly with heart disease and cancer, and even COPD and stroke being these chronic illnesses, this obviously affects much about death, right? These aren't really quick things most of the time, and are trying to be managed on a chronic basis and affect where people die and how they are spending their last months and years of life. So where do people die in the United States? Well, I'm going to answer that question for you, but first, I want you to take a few minutes and do a thought exercise. Now, I don't mean this to be morbid in any way. I do actually think you might find this helpful. What are your criteria for a good death? Where are you? And who is with you at that time? And I'm going to pause here for just a minute while you think about that. What are your criteria for a good death? You can certainly pause this longer if you want more time to think about that, since this is recorded, but I'm going to move on here. When I ask this to folks, and when other people ask this, there are some common ideal death scenarios we might talk about, and common themes with this. So things such as being at home, being comfortable, having a sense of completion, having the opportunity to say goodbye to loved ones, having a life review, and being surrounded by love. Many folks will say they'd like to suddenly die in their sleep. Again, most folks will say they want to die at home. And some people would say they'd like to die engaged in meaningful activity, which can be a variety of things. But those are just sort of the common themes that most people within the United States have. Not everybody, different backgrounds and different, cultural or religious backgrounds can affect this absolutely, and there is no right or wrong answer. But when polled, most people have something along this line. Now you'll notice few, if any, ideal deaths say they want to be in a medical setting when surrounded by medical staff, physicians and nurses, right? I've never once had anyone say to me, I want to be on a ventilator with a breathing tube and medically sedated for 2 weeks and force my children to decide when it's time to turn the machines off. No one's ever told me that. However, I can't tell you how often it's been that I've run into that exact scenario in the hospital. And we're going to talk a little bit about ways we can maybe try to avoid that, unless that happens to be your ideal death scenario. But again, I've never come across anyone where that actually is. Now, part of this is because physicians in general receive much more training in extending life than we do in planning for the end of life. And so often we tend to push to try to do everything we can to extend life. Now, this is where we really receive a lot of help from our palliative care colleagues, as they are very well suited and receive very excellent training in helping with discussions on end-of-life care, and particularly having those discussions before it's imminently needed. Doing that in advance, I can't tell you enough how important that really is. So, where do people die in the United States? We'll come back to this question. Well, as we just said, 80% of people state that they'd like to die in their home. Well, where do they actually die? Well, looking at some numbers, we really only have good data going back to the 1970s. Certainly in 1900, when we were looking at things. The medical system was very different, and most people died at home. From the 1970s on until very recently, most people died in hospitals. In 2003, it was about 40%. It's actually down to about 30% in 2017. And then at home, which can either be private homes or nursing homes, the death in nursing homes down a little bit, whereas dying at a private home is increased. And this is mostly due to an increased utilization of hospice, as I'll show you on the next slide. But also passing away within a hospice facility or a hospice house. 2003, almost no one did. But as this has really become more and more common and well known both among patients and with us in the medical community, this has increased dramatically as well, from almost non-existent to being 8% of folks who pass away. And then there's always some that'll pass away in other scenarios. So accidents, car accidents, or other places where they're not in any of these situations. Now, I will point out, even though the number of folks that are dying at home has increased, this is still dramatically lower than it is in Canada and the United Kingdom, where it's 40, 50, 60% of folks dying at home. And again, 80% state they would like to die in home, but between private homes and nursing homes, we aren't reaching that. So of those who die, how many are enrolled in hospice? Well, here's a few interesting numbers. In 1993, 11%. In 2000, 21%. In 2015, it then crossed over more than half of people who are dying enrolled in hospice. And the numbers have even gone up a little bit further since then. Not quite as dramatically as the jump from 2000 to 2015. Now, another interesting statistic is end-of-life ICU care, meaning within the last month of their life, how many people have been in an ICU or an intensive care unit. Well, in 2000, 65%. In 2015, less than 30%. Now, again, in many cases, an ICU may be very appropriate as folks are moving towards end of life. But there's many cases where we recognize what we can and cannot accomplish in an intensive care unit. And as more folks are having discussions ahead of time about what they want or don't want to have happen as they move closer to the end of their life, this is becoming more reflective probably of that. Now, the expense of dying, which is very closely tied with being hospitalized, especially in an intensive care unit versus not. Well, 85% of all end-of-life expenses are publicly funded, meaning by Medicare and Medicaid. And the last 6 months of life, the cost of that, now this is really variable from different studies, but probably sits somewhere about 7.5% of a person's total healthcare expenditures for their entire life. About 7.5% of that is spent in their last few months of life. Again, there's some studies where that number is dramatically higher. But of great interest to this discussion is that those enrolled in hospice, that number is reduced by half. It's much more cost effective for people to be enrolled in hospice than it is not to. And those that are enrolled in hospice report better quality of life, and the families are more satisfied with the dying process than those who aren't enrolled in hospice. So frankly, it's a win-win-win situation. It's a wonderful thing that's becoming more and more well-known and more utilized, and I hope it continues to do so. Now, as we're coming close to the end here, I want to talk a little bit about goals of care. It's very important to have specific goals of care discussions with all close family members or medical decision makers before becoming critically ill. I mean, this is amazingly helpful, and I can't emphasize this enough. Um, Again, how many times I've been in situations in the hospital, someone comes in critically ill, they haven't had these discussions with family members, and their children are trying to decide what to do. And sometimes different children have different perspectives on this. Some want to try everything. Others would rather, they think that the patient would prefer to move more towards a hospice route. And this can enter very tricky ethical and legal battles. It can become also, again, very expensive. Now, if the patient wants everything done, then by all means, that's what we would want to do. We want to do whatever the patient would like. If the patient would not want extensive measures done and would rather go in a more comfort care type of route, then that's what we should do. But often it's hard for us as physicians to know, and in cases sometimes the family members aren't sure. So having these discussions before we get to this critical situation is very important. Now, this can be done in written form in an advance directive or living wills, but honestly, even more important than that, whether something's written down or not isn't the critical issue here. It's really that all family members or medical decision makers know what a patient's wishes are, and that they're all on the same page, so that when it comes to this time, there isn't questions about it. These discussions can begin with the primary care physician if needed. Certainly, palliative care consultation can be very helpful in times like this, either with the patient and their spouse, with the children, as the whole family. But having these conversations ahead of time, again, is just critically important. So to summarize all of this together, palliative care can be utilized at any time for symptom control. Again, so from early on in symptoms through advanced disease and into hospice care. Patients are more satisfied and costs are lower when palliative care is consulted early. Hospice focuses on end-of-life care. Specifically, think with the assumption that the patient has 6 or fewer months left to live. It can be done at home, in a hospital, or in a hospice house. Patients and families, again, are more satisfied and costs are lower when hospice is utilized early, rather than in just the days before a patient dies. And goals of care discussions with loved ones should happen early and as frequently as needed. If goals of care change, if a patient at one point decides they want something done and then later decide not to, having those discussions with family members as frequently as needed is helpful. If having this written down in an advance directive or living will is great, but more importantly is making sure that all the family members or medical decision makers are on the same page with what a patient's desires are ahead of time, when they're able to actually express those, and not once they have become incapacitated. So I wish I was there with you personally to take your questions and answer them directly. Obviously, we can't do that right now. However, if you have any burning questions you want to discuss with me, here's my email. Please feel free to contact me. I'd be happy to discuss any of these with you. And I wish you all well, and hope that when I come to speak with you on another topic, hopefully next year, that we're all able to meet in person at that time. I wish you the best. Bye-bye.